Last week, before I start on the slides per se, last week I had a patient who is a diabetic, thin, lean individual, and she's been having uncontrolled diabetes for the past 2 or 3 years, and she was in sepsis when she came to me, and she had a gluteal abscess, and her sugar was 300, 400 when she came, and her A1C was also very high, 14.9. So obviously I admitted her, and she was in mild ketosis as well. So I admitted her, and we put, the gluteal abscess was drained, and first 2-3 days she was doing well with insulin. I switched over from the OHA to the insulin, and her blood sugar was around 200 to 250 in spite of insulin, 30 units, 35 units per meal. So she was taking around 100 units per day. So all of a sudden, on 4th day, she became better. She became afebrile, so as she was taking her food, there was no nausea, vomiting, so she started consuming her normal diet, and her acidosis settled, and everything, all the vitals were stable. So everything was switched over from the IV antibiotics were switched over to oral, but I continued insulin because she tended to have be in hyperglycemia still. But 4th day, she went into hypoglycemia. Suddenly her blood sugar was 70. So next day, I checked all my case sheet, my prescription, and her blood sugar was continuously between 60 to 70 in spite of decreasing the dosage. So what had happened to this patient? Why she went into recurrent hypoglycemia in spite of having A1C of around 14.9, insulin she was taking 100 units per day. All of a sudden she started having recurrent hypoglycemia in spite of reducing the insulin. What particularly happened to her was, I had switched over from parenteral antibiotic, IV antibiotic, to oral antibiotic. I had started her on cotrimoxazole. So that was the culprit. So that sulfamethoxazole and trimethoprim. The sulfamethoxazole is very notorious when you combine with other sulfonylureas or insulin, even insulin, in causing hypoglycemia. But I have not witnessed so far such a drastic change in insulin requirements by putting this particular drug. So this is one example of drug interaction what you have in your clinical experience. So there are many drug interactions which we don't know, which we are not aware of. So one question was raised whether the oral semaglutide can be combined with thyroxine. So the answer is you have to give it apart 30 minutes because the thyroxine level goes up by 30%. So you have to give oral semaglutide first. After half an hour you can give thyroxine, and after 1 hour or 2 hours you can consume your food. And again, another question was raised whether the ATT can be continued if the patient is on insulin, whether you want to put the patient on insulin. Among ATT, rifampicin is a notorious drug. It is an enzyme inducer. So that will again interact with sulfonylureas, and that will again decrease the effect of sulfonylurea so that the sugars can go up. That is one of the reasons why we switch over to insulin, because rifampicin as well as isoniazid are enzyme inducers. So we do have many drug interactions like this. So we are just going to see few examples. So to put it in a textbook way, it is defined as modification of the pharmacological effect of one drug by the prior or concomitant administration of another substance. I have not put it as another drug here because drug or food or beverages or even the disease states per se can interact with a given drug. And what is an object drug? Object drug is nothing but which drug's effect is modified. So what is the precipitant here? It's either a drug or, as I said earlier, it can be food, it can be beverages, or it can be a disease state itself. Next slide. Next slide, Pole. Okay. So why do we worry about this drug interactions? One thing, it can lead to toxicity within a very short period of time. We are worried when you talk about narrow therapeutic index. Drugs like digoxin, which can cause fatal arrhythmias and even death. And lithium, yes, the side effects, the toxicity is detrimental. So other group of drugs where you have high plasma protein binding drugs like warfarin. So if some drug interacts with this particular warfarin and displaces the warfarin from the protein binding site, then the warfarin, the toxicity can happen and it can cause bleeding. And other set of group of drugs like closely regulated body functions like antihypertensives or OHAs, which I said earlier. So those kind of drugs we still worry about. And of course, we do have drugs like those who get metabolized by saturation kinetics like phenytoin and theophylline. So we do know what phenytoin toxicity can do. It can cause ataxia, it can cause nystagmus, so it can cause altered mental status. So, and theophylline, yes, again it can precipitate arrhythmias. So these are the drugs which we are worried about. And other drugs like precipitants we have already discussed. But when we talk about drug interactions, is it always undesirable? No, we do take advantage of these kind of interactions and make it more beneficial. For example, when we talk about sulfamethoxazole and trimethoprim, they are bacteriostatic individually. But when they are combined, they become bactericidal. So that is a desirable effect here. And next, again, another quite good example is furosemide and amiloride. So when you give furosemide, you worry about hypokalemia. But when you combine with amiloride, which is potassium sparing, then again, this hyperkalemia and hypokalemic effect get nullified and we don't get any fatal hypokalemic events. So these are the part of desirable effects due to drug interactions. Of course, we do have undesirable, which are most of them, like complete loss of therapeutic effect. We know levodopa, which is used in Parkinson's, and it is a dopamine agonist, and chlorpromazine is dopamine antagonist. So when you combine them, it's not going to do any benefit to the patient. So this is called antagonism. And increase adverse reactions. We have been told in pharmacology repeatedly, don't combine beta blockers with digoxin because it can decrease the BP and as well as it can cause bradycardia. So those, both digoxin itself can cause AV nodal suppression as well as propranolol. So both of them can cause significant bradycardia. Again, warfarin and clopidogrel can increase the bleeding manifestations. So these, definitely there are undesirable side effects. So how else we can categorize, to make it simple, we'll just categorize into in vivo and in vitro drug interactions. In vivo, we do have two types. One is pharmacokinetic and another one is pharmacodynamic, which is we are going to see in detail now. And in vitro, we do have some drug incompatibilities, which we'll just talk. So whenever we talk about pharmacokinetic interaction, there are four things. One is absorption, another distribution, and third one is metabolism, and the fourth one is elimination. So this comes under pharmacokinetic interaction. Whereas what is pharmacodynamic interaction? One is agonist, that is synergistic effect. So we combine always penicillin with amikacin. So because they have synergistic effect. So that is the example of agonistic action. Again, antagonist. We do give in benzodiazepine poisoning flumazenil. So that is like antagonism. Morphine, opioid poisoning, you give naloxone. So they are completely, they do have complete antagonist effect, and they again can be used in toxicity. Complete abnormal response, which is like bizarre kind of reaction, which I'll talk in a short while. So coming to absorption as such, there are various factors. All the listed factors can be affected by the precipitant so that the absorption of the object drug is decreased or increased. So each one we'll see like whether there is an alteration in gastric pH. We just talked about oral semaglutide, how the gastric pH can affect a drug. Complexation, GI motility, and presence of food. Again, thyroxine we just discussed now. GI flora, malabsorption, and some enzymes. So gastric pH, we know acidic drugs need an acidic medium so that it becomes ionized from unionized molecule, and that's how it gets absorbed. So once the pH is disturbed by giving antacid, for example, itraconazole, does not get absorbed. So you should not combine itraconazole with antacid. So any antacid should be given 1 or 2 hours after consuming food. So that is the ideal way. This is the reason behind it. And bisacodyl plus antacid. What happens? Bisacodyl comes in an entry-coated tablet. So it needs a basic pH. So once you give antacid, it assumes that in the stomach itself there is a basic pH. So it starts disintegrating early in the stomach itself. So the effect decreases. And again, aspirin and antacid should not be combined. So we should keep all these factors in mind when you always combine a drug. Again, complexation. So a drug has to be in a soluble form to get absorbed. For example, when the tetracycline is combined with antacid, calcium or magnesium, what happens is it forms an insoluble complex which does not get absorbed. So that's why it is not recommended to combine tetracycline with antacid or calcium and magnesium. The same thing is applicable with penicillamine. Again, iron. Iron should not be combined. And again, ciprofloxacin with iron, calcium and antacid should not be combined. So this is the rationale behind it. And what happens to GI motility? It can increase the rate or it can decrease the rate. For example, prokinetic, we do have metoclopramide. So once it is combined with paracetamol, it increases the the rapidity of absorption is increased. The rate of absorption is increased. So that is why in migraine, what we do, in migraine usually there is gastric dysmotility and they have vomiting. So once you combine a prokinetic drug or a domperidone with a paracetamol, the absorption of the paracetamol gets better so that this combination works better for them. That's why we always combine paracetamol with domperidone in treatment of migraine. So we always tend to make use of such interactions also. And extent, again this metoclopramide increases the duration of absorption of cyclosporin. So this is how the GI motility comes in to play when we talk about absorption. So the presence or absence of food, we do know it decreases. The presence of food, there is a long list of all the antibiotics which gets, the absorption is disturbed here. Isoniazid, we all know it has to be given in empty stomach. So the food has to be consumed after half an hour whenever you take isoniazid and rifampicin. And ampicillin, azithromycin, quinolones, tetracycline. So all these antibiotics should not be given in the presence of food. But there is one drug which can get increased absorption is in the presence of food, is that itraconazole. So we should be aware of all these factors. Coming to GI flora. So we know some drugs get metabolized and absorbed in the large intestine where the GI flora happens to be the determining factor. So when we combine with digoxin and tetracycline, so what does the tetracycline as an antibiotic do? Decreases the metabolism of digoxin by GI flora because the entire GI flora is disturbed by tetracycline. So the metabolism of digoxin is decreased and thereby it can cause toxicity. So never combine digoxin with tetracycline. Again, the same thing happens in warfarin. No GI flora, so no vitamin K making in the large intestine. Again, more warfarin and more bleeding. OCPs and tetracycline. Again, no GI flora, so there is no free form available. The OCPs, they have to get converted from conjugated form to free form in the large intestine by GI flora. So that does not happen when you combine with tetracycline. So there is no free form, no enterohepatic circulation, so decreased OCP effect, the patient can get pregnant. So this is how the GI flora plays. And what about malabsorption? Laxatives, yes, it can decrease the absorption of vitamins and nutrients. Again, this is very peculiar example where a two drug can interact. So whenever we put the patient on phenytoin for a long term, there is definitely a deficiency of folic acid. We supplement with folic acid, usually, only in the long term. But what happens is, because that is a cofactor for metabolism of phenytoin, so there is folic acid deficiency in the long-term usage of phenytoin and you supplement, the folate deficiency disappears. But at the same point, phenytoin, as I said earlier, folic acid is a cofactor of metabolism of phenytoin. So increased folic acid, when you supplement folic acid in the initial stage, it increases the activity of an enzyme called intestinal conjugase enzyme. So it increases the phenytoin metabolism, thereby it decreases the phenytoin activity. So this is like two-way action. Both the phenytoin can interact and the folic acid can interact. So we should know in which period you are in and you should supplement according to that. So I have talked so far about absorption. Next, coming to distribution. So distribution, we all know, for example, warfarin, they get bound to protein binding sites. So we do have bound form and free form. Free form is available for action. And so when you combine any drug which can displace a particular drug from that protein binding site, then the toxicity of the object drug can happen. So that is what can happen when you combine methotrexate with aspirin. Phenytoin with valproate. Valproate can displace phenytoin and the phenytoin toxicity ensures. Again, phenylbutazone with warfarin. So coming to metabolism, we do have famous enzyme inducers and enzyme inhibitors. So what they do, enzyme inhibitors increase the metabolism of the drug. They can lead to faster clearance. And enzyme inhibitors, what they do, decrease metabolism and clearance, therefore toxicity can happen. So these are the various famous inducers and inhibitors which we have been trying to mug up since our pharmacological days. So enzyme inducers, phenytoin, carbamazepine, rifampicin, as I said, this is the mother of all enzyme inducers. And of course, cigarette smoking. This can act as an enzyme inducer, barbiturates and famous herbal medicine, St. John's wort. Again, enzyme inhibitors like grapefruit and azole antifungals like the fluconazole, cimetidine, macrolides and sulfonamides. So these are the famous, enzyme inducers. Phenobarbital decreases the metabolism of increases the warfarin metabolism. Rifampicin on HIV protease inhibitors. Rifampicin again on OCPs. Phenytoin on cyclosporin and alcohol on warfarin and phenytoin. So this, if you combine, these are enzyme inhibitors by the way. So if you combine cimetidine and disulfiram with warfarin, it can cause toxicity. Alcohol and disulfiram on phenytoin. Again, cimetidine and erythromycin or fluoroquinolones on theophylline. And verapamil on carbamazepine and allopurinol on azathioprine. So we have talked about absorption and distribution. We have come to elimination. So that is renal tubular excretion can be altered, urinary pH can be altered and active transport can be altered. So acidic drug, urinary pH, we all know acidic drug needs an acidic medium so that the unionized form gets absorbed. Acidic drug, basic medium, then ionized, it gets eliminated. So example is phenobarbital on salicylates, quinidine on amphetamine. So this is again we know renal tubular secretion, the probenecid decreases the renal tubular secretion of penicillin so that the duration of penicillin increases. Probenecid on methotrexate, same way. Quinidine on digoxin, aspirin on methotrexate and NSAIDs on lithium. This particular protein called P-glycoprotein, this is present in gut, gonads, brain and kidneys. So this protein's job is to eliminate the harmful substances from these four organs. And they increase the substances eliminated through renal and biliary system. So the substrates like digoxin, cyclosporin, diltiazem, verapamil, all these things can cause toxicity. So this particular PGP will try to always eliminate such kind of drugs. But there are enhancers and inhibitors. So if you combine with enhancers like rifampicin, clarithromycin and verapamil, toxicity ensures, and the inhibitors, quinidine, again the effect is decreased. So we should be very careful. So again digoxin, when it is combined with quinidine, it decreases the renal and biliary excretion, thereby it can induce digoxin toxicity. Again digoxin with verapamil and loperamide with quinidine. So that brings us to the end of pharmacokinetic drug interactions. Next, coming to pharmacodynamic. I already told you agonistic action or synergistic. Another example we do have here, that is trimethoprim and sulfamethoxazole. We explained it in detail in the previous slides. And we do have another such drugs like aspirin, clopidogrel or ticlopidine. When it is combined with carbonicillin, the bleeding can worsen. And ACE inhibitors with diuretics, the antihypertensive action is enhanced. So coming to antagonism, we talked about levodopa and chlorpromazine. Another set of example is beta-lactam antibiotics. When it is combined with bacteriostatic antibiotics like clindamycin, azithromycin or tetracycline, it inhibits the bactericidal action of beta-lactam and it almost makes it as bacteriostatic. So never combine them. So as I said, the another set group is bizarre reactions. We all know when metronidazole or cephalosporin is combined with alcohol, we do get disulfiram-like reactions where do get excessive flushing, sweating, tachycardia, palpitations, which is completely unpleasant and undesirable. So coming to the end of in vivo pharmacological drug interactions, now we can talk about in vitro reactions. They are called as pharmaceutical incompatibilities. We have all must have learnt in internship, never put phenytoin in dextrose 5D. So it gets precipitated. That is one of the example. And again, amphotericin in IV saline. And again, in the same syringe, you don't mix beta-lactam antibiotics with gentamicin. Again, it gets precipitated. So coming to next set of drug and food interactions, we have been told, anyone can tell me at what time you give warfarin in a day? 6 o'clock. Why? 6 p.m. We always tell the patient to take warfarin at 6 o'clock in the evening. Any particular reason anyone knows? No. That is not because of any food interaction. Because that was said so, they will wait for the PT-INR value to come. Morning, if you give the blood sample, it will reach by evening, and on the same day, if the INR is too high, you can modify the dosage. That is the idea behind taking warfarin at 6 p.m. That's why we follow that. It's not because of any interaction. And warfarin should not be taken with green leafy vegetables, citrus fruits or egg yolk. Any particular reason? All these green leafy vegetables, citrus fruits and egg yolk are rich in vitamin K. So, warfarin is a vitamin K antagonist. So, when you take such kind of food with warfarin, it reduces the action of warfarin and the PT-INR cannot be maintained. That's the reason behind it. But the griseofulvin is told to be taken with the fatty food because it increases the absorption of griseofulvin. Again, drug beverages interaction, alcohol mainly with sedatives, benzodiazepine. So when you consume benzodiazepine with alcohol, the sedative action of benzodiazepine is much increased and you should be very careful. Then coming to, again, warfarin. We don't, the grapefruit is not available here in our country. Nowadays, maybe in some cuisine hotel, multi-cuisine hotels you might get. But we don't take usually grapefruit juice or cranberry juice. But that has got a definite interaction with warfarin and that is absolutely contraindicated. So disease states, we all know renal disease, albumin is excreted. So there is no albumin binding volume in renal diseased patients. So again, there can be interactions. The same thing with liver disease and hypothyroidism. So if you have time, so, pa mudsetla? Offer? Okay. Okay then, I had some case examples. Okay then. Okay. Okay, I just have few more slides where we do have common drugs, common drug interactions. So one such, because I couldn't cover entire thing in the previous slides. So I'll just list out the drugs.
you should be very careful when you combine amiodarone with digoxin. All these are usually the CV drugs or neuro drugs. So digoxin, warfarin, phenytoin, verapamil, diltiazem and grapefruit juice. So all these things should not be combined with amiodarone. Warfarin, again as I said, amiodarone, cranberry juice, fluconazole. Many patients we just give 1 or 2 doses of fluconazole for vaginal itching. The patient may be on warfarin, we may not know, the INR will become low and they'll come to us. So omeprazole, I have a particular slide on omeprazole. I just wanted to highlight that. NSAIDs again and quinolones and alcohol. So I think we have discussed this. Theophylline, again a narrow therapeutic index. So cigarette smoking, as I said, that is a great enzyme inducer. Most of the patients with COPD, if they consume, if they continue to smoke, the theophylline effect cannot be achieved. So you have to increase the dosage or they should stop the smoking. And diuretics, again, rifampin, again, erythromycin, cimetidine, phenytoin and ciprofloxacin. Statins, so any changes in the prescribed drug can cause, if they are on statins, especially the high doses, and they can develop myalgia, particularly severe myalgia or even rhabdomyolysis if there is any tilt in the dosage of the precipitant drug. So such drugs are like macrolides, again grapefruit juice, fusidic acid, fluconazole and colchicine. So these drugs, again fluconazole comes here. We give lots of fluconazole in cardiovascular patients, but we should be very careful. Macrolides again. Macrolides, they tend to increase the QT prolongation. During COVID times, we talked about azithromycin so much. Azithromycin, HCQs, they can increase the QT syndrome, in QTC interval, and they can cause arrhythmias. So we should be very careful. And methotrexate again, trimethoprim, NSAIDs, omeprazole again, quinolones and penicillin. Here, MAO inhibitors, foods rich in tyramine, like sympathomimetics. Here, again as GPs, we tend to give pseudoephedrine, which is present commonly in cough med. So if the patient is on MAO inhibitors, they can go in for sudden hypertensive crisis. We should be aware of. Again, sumatriptyline and lithium. Yes, omeprazole. So how many of us give omeprazole every day to at least minimum of 10 to 20 patients? But in cardiac patients, those who are on clopidogrel, warfarin, we should be very careful because it is also an enzyme inducer, but not pantoprazole. Pantoprazole is safer. So omeprazole should not be given along with clopidogrel because it decreases the action of clopidogrel. You should keep that in your mind, as well as the same thing happens with warfarin. And there are case reports where omeprazole combined with citalopram and escitalopram, these are SSRI, they have gone into serotonin syndrome. So omeprazole is a very notorious drug and we should be very careful. Again with methotrexate, which should not be combined. So digoxin, we all know. Calcium. If the patient is on digoxin, never give calcium tablets. We give as GPs, we give calcium tablets to almost everybody. So that should not be combined because it synergizes with digoxin and it can precipitate toxicity. Again, propranolol, verapamil, diltiazem, all those things should not be given with digoxin. I think we discussed that. So coming to the last set, that is antibiotics. Ampicillin and amoxicillin should not be combined with oral contraceptives, again because the enterohepatic circulation is disturbed and OCP effect is decreased. Ampicillin, amoxicillin plus warfarin, again the inhibition of gut flora is there. All these antibiotics can disturb the gut flora. So there is no vitamin K, and so that there can be increased risk of bleeding. Again, carbonicillin, ticarcillin plus aspirin can increase the risk of bleeding. Ceftriaxone and cefoperazone with warfarin, they can cause bleeding. And cotrimoxazole sulfonamide with, or cotrimoxazole with phenytoin, again, phenytoin toxicity. With warfarin, it can cause bleeding. And with sulfonylureas, as I said, as an example, hypoglycemia. We discussed about penicillin and probenecid, and again allopurinol with azathioprine. So that's the end. Thank you.
It's not the question. Really very nice, madam. This way back as though we have attended a pharmacology class at Stanley Medical College. Anyway, it is really very, very useful. Now we are really afraid to give any combination of drugs. My suggestion to you, make the table, right? And within 2 or 3 days, within this week, you send through this WhatsApp in this group. It will be very, very useful for everybody. And sincerely, I request.
I'll just do it, sir. But
Yes.
you have an app everywhere in the Google now. If you type the 2 drugs, for example, digoxin plus quinidine, whether there is any interaction, you get the answer immediately. There are many apps available.
Those are all really very difficult for us in the practice. You just do this, it will be very, very useful.
Okay, sir. The test PT-INR, usually they take it in the morning. So by the time they get the report, usually we get the report in the afternoon. And if you take the tablet at 6 o'clock in the evening, if by chance, if the INR is more than 3, on the same day, you can decrease the dosage of warfarin. And if it is low, you can increase. You need not wait for another 24 hours. So that is the logical science behind taking warfarin at 6 p.m. It's not because of any interaction as such.